Hi everyone, this is the presentation for the online assignment for this Friday. We're going to be talking about a lot of disorders in this presentation. So there's a lot of information, but I grouped these disorders together on purpose because these are typically disorders that you will not be diagnosing by yourself. You will definitely probably treat clients that have these disorders, but a lot of them are medical diagnoses. So typically clients will come to you. There's a lot of comorbidity around depression and anxiety in substance use with these disorders, so you will probably be treating that as well. The way that this PowerPoint is going to work is there's going to be little videos for you to watch after each disorder that we talk about. So there's a copy of the PowerPoint that's also available on Blackboard. So if you want to follow along, you can just copy and paste the link from the PowerPoint that's on Blackboard into your browser and watch the video. What I will do is I will stop talking so you can watch the video before we move on to the next disorder. It's going to be important that you watch them in order, just so it's easier to remember all of the information. So let's get going. So the first one that we are going to talk about is somatic symptom disorders, and there were some changes from DSM-4 to DSM-5. So I kind of want to highlight those first before we move into the DSM-5 diagnostic criteria. So DSM-5 replaced what was called somatoform disorders with somatic symptom and related disorders, and makes significant changes to the criteria to eliminate overlap across the somatoform disorders and clarify their boundaries. And just as a side note, all of this information that I'm giving you, and a lot of the information that I gave you in the prior PowerPoints too, comes from the American Psychiatric Association. There's a 2013 published changes from DSM-4 to DSM-5 that you can access online if you're interested in those. I can give you links to find those as well, but a lot of the information I'm telling you is located there. So the changes from DSM-4 to DSM-5 better reflect the complex interface between mental and physical health. Individuals with this disorder typically present in medical rather than mental health settings. So typically, clients will first present with their primary care physician and then be referred to you for treatment. So characteristics of somatic symptom disorder. It's characterized by somatic symptoms that are either very distressing or result in significant disruption of functioning, as well as excessive and disproportionate thoughts, feelings, and behaviors regarding those symptoms. And we'll talk about those a little bit more when we get to the next slide. To be diagnosed with SSD, the individual must be persistently symptomatic for at least 6 months. Several important changes have been made from previous editions of the DSM. The DSM-4 disorders of somatization disorder, hypochondriasis, pain disorder, and undifferentiated somatoform disorder have been removed, and many but not all of the individuals diagnosed with one of these disorders could now be diagnosed with SSD. So this is important for you because if you request records from your clients from previous treatment that they've had, and you see that they have been diagnosed with one of those disorders, so somatization disorder, hypochondriasis, pain disorder, and undifferentiated somatoform disorder, now you would diagnose them with somatic symptom disorders because those other disorders are no longer in the DSM. So the DSM-4 diagnosis of somatization disorder required a specific number of complaints from among 4 symptoms groups. The SSD criteria no longer have such a requirement. However, somatic symptoms must be significantly distressing or disruptive to daily life and must be accompanied by excessive thoughts, feelings, or behaviors. Another key change in the DSM-5 criteria is that while medically unexplained symptoms were a key feature for many of the disorders in DSM-4, an SSD diagnosis does not require that the somatic symptoms are medically unexplained. In other words, symptoms may or may not be associated with another medical condition. DSM-5 narrative text description that accompanies the criteria for SSD cautions that it is not appropriate to diagnose individuals with a mental disorder solely because a medical cause cannot be demonstrated. Furthermore, whether or not the somatic symptoms are medically explained, the individual would still have to meet the rest of the criteria in order to receive a diagnosis for SSD. So even if your client comes in and they're having all of these somatic symptoms and they cannot be explained medically, that is not enough to be diagnosed with somatic symptom disorder. They also need to have the accompanying excessive thoughts about it, the anxiety around it, and the distressing thoughts around the pain or whatever symptom that they are having. So the well-tested DSM-5 criteria for SSD remove overlap and confusion from previous editions and encourage comprehensive assessment of patients for accurate diagnosis and holistic care. That's good. We're moving towards promoting holistic care. The DSM-4 criteria included a large number of disorders that overlapped and made it difficult for primary care providers to effectively isolate the problem plaguing their patients. Because those suffering from SSD are primarily seen in general medical settings as opposed to psychiatric settings, the criteria in DSM-5 clarify confusing terms and reduce the number of disorders and subcategories to make the criteria more useful to non-psychiatric care providers. To ensure that the new criteria would indeed help clinicians better identify individuals who need care, scientists tested the SSD criteria in actual clinical practices during the DSM-5 field trials, which is very interesting. SSD's diagnostic reliability performed very well in these field tests. Comprehensive assessment of patients requires the recognition that psychiatric problems often co-occur in patients with medical problems. While DSM-4 was organized centrally around the concept of medically unexplained symptoms, DSM-5 criteria instead emphasize the degree to which a patient's thoughts, feelings, and behaviors about their somatic symptoms are disproportionate or excessive. So it's really about their thinking, less so than it's about the actual somatic symptoms that they're having. This, in turn, may enable them to access treatment for these symptoms. In this sense, SSD is like depression. It can occur in the context of a serious medical illness. It requires clinical training, experience, and judgment based on guidance such as that contained in the DSM-5 text to recognize when a patient's thoughts, feelings, and behaviors are indicative of a mental disorder that can benefit from focused treatment. So this also is about managed care, because now these clients that have these unexplained medical somatic symptoms also have the cognitive distortions around them and then qualify for treatment under mental health professionals. Like, you can bill for it, basically. This change in emphasis removes the mind-body separation implied in DSM-4, which is huge, and encourages clinicians to make a comprehensive assessment and use clinical judgment rather than a checklist that may arbitrarily disqualify many people who are suffering with both SSD and another medical diagnosis from getting the help that they need. So DSM-5 is definitely moving on the right track in terms of being able to get care for these patients. So here is the DSM-5 diagnostic criteria for somatic symptom disorder. We've talked about most of this already. So one or more somatic symptoms that are distressing or result in significant disruptive of daily life. And then the thinking, the cognitive distortions around it. So excessive thoughts, excessive feelings, excessive behaviors, right, related to the somatic symptoms as manifested by at least one of these. So disproportionate and persistent thoughts about the seriousness of one's problems or symptoms, persistently high level of anxiety about health or symptoms, and then excessive time and energy devoted to these symptoms or health concerns. And you can just imagine what that does to a person's social, occupational, or other areas of functioning. If you're spending all this time and energy devoted to why you are feeling any sort of range of somatic symptoms, you're not going to have much time for anything else, right? And this might also look like an anxiety disorder or a depression disorder, because of the level of anxiety around it, or because I'm thinking about this illness all the time and now I'm not doing things that I used to do, and now I'm isolating myself, which would lead to depression. And then although anyone's somatic symptom may not be continuously present, the state of being symptomatic is persistent, so longer than 6 months. And then you would specify in your coding if it's with predominant pain, if it's persistent, if it's mild, moderate, severe. At the bottom of the slide is the 2013 American Psychiatric Association citation, where a lot of our information is coming from. So I can definitely get you that if you would like it. So the epidemiology of somatic symptom disorder. According to the DSM-5, the prevalence rate is unknown in the general population, but it may be around 5% to 7%. Females report more somatic symptoms than males. It's more common in older populations, and this is interesting because the DSM-5 talks about how, even though it's more common, it might actually be underdiagnosed because certain symptoms, so pain, fatigue, whatever, are within the realm of normal for older adults. So this is stuff that the older adults, frequently talk about. If you think about your grandmother or your great grandmother, talking about how they feel, what symptoms they have, and you might think, oh, that's totally normal. Grandma or grandpa are getting older, and that's what older people talk about. But actually, they can be suffering from a somatic symptom disorder, and it just could be undiagnosed because of where they are in the context of their life. In children, the most common symptoms are recurrent abdominal pain, headache, fatigue, and nausea. And I thought that this was really interesting. It's the parents' response to the symptoms that's important in children, because typically when kids get sick, they just get sick. They don't worry about their illness. They don't have this excessive anxiety around, oh my God, I'm having these symptoms. What does that mean? But the parents might have that symptom around that too, and that's what might prompt treatment. I'm sorry, I have typos in this. What may prompt treatment? So what I would like you to do is to stop now and to watch the video that's at the bottom of this slide. And then when you come back to this, just pause it on YouTube, and then when you come back, we'll start on the next slide. So I hope that video was helpful in understanding a little more about somatic symptom disorder. I want to continue the conversation and talk about risk factors. So risk factors for developing this disorder. Some temperamental risk factors. So negative affectivity as a risk factor. Gender, female sex, gender typically report more somatic symptoms. Older age. I thought these were interesting again. Fewer years of education, lower socioeconomic status, and unemployment. Is a risk factor. A history of sexual abuse or childhood adversity. Concurrent chronic physical illness or psychiatric disorder. So other things are going on along with the symptoms. Social stress, reinforcing social factors such as illness benefits. So that's when the client, they're getting something out of being sick. They're getting something out of having these symptoms, whether it's attention from medical providers, attention from their family, but there's some sort of benefit that's coming with this. Sensitization to pain and heightened attention to bodily sensations, and then attribution of bodily symptoms to possible illness instead of normal stress. So I'm getting headaches all the time, and it's got to be because it has to be because I'm ill, and it's not because I am just totally stressed out all the time. So comorbidity, definitely comorbid with other medical disorders, depression and anxiety, which we talked about a little bit earlier. And then treatment. So there is no consensus on the best psychological treatment for somatic symptom disorders, as there have been insufficient studies to warrant a meta-analysis. However, review of published studies has found that, shocking, CBT appears to be the most promising psychological approach for managing health, anxiety, somatic symptoms, and pain. Although several variations of CBT have been employed, two elements are common to all. So cognitive therapy, this allows for the identification and modification of unhelpful beliefs about symptoms and disease. That's where you're going to do your psychoed piece. And then behavioral techniques. These are helpful to alter illness and sick role behaviors, resume engagement in normal activities, and promote more effective coping. While undergoing more targeted psychological intervention is also important to encourage individuals to do the following. So monitor symptoms to help identify psychosocial factors, so time, situations, and emotional states which exacerbate their symptoms, emphasizing the links between psychological factors and the experience of somatic symptoms. Assist the patient or the client in managing these perpetuating factors through strategies that may include anxiety management, problem solving, facilitating engagement with social support, etc. Maintain or reestablish daily routines and current roles. This is particularly important for patients who might be unemployed, who have a lot of unstructured time. If they're using substances, help them to reduce their substance use. It's common for individuals who are suffering with somatic symptom disorder to medicate with alcohol or other drugs when struggling with pain. While alcohol and drugs may alleviate distress and somatic symptoms in the short term, they inhibit recovery. Pain management programs. So pain management programs are the treatment of choice for individuals suffering from chronic pain syndromes, including somatoform pain disorders, shortened to PMPs, pain management programs. So effective PMPs adopt an explicit biopsychosocial model embedded within a cognitive behavioral paradigm and include the following elements. So a multidisciplinary team, a holistic view of the client, education on pain coping strategies, promotion of self-efficacy beliefs and self-management, support for improved function and lifestyle, targeting of related depression and anxiety, and encouragement for improved general physical health and fitness. And then you could do PMPs in a group setting, and you could do them for 2 weeks or 6 weeks or whatever duration works for you. So that's something that you will be able to do as a therapist. So let's see, treatment setting and duration. In research studies, CBT treatment for somatic symptom disorders varies between 6 and 16 sessions. It is likely that 16 to 20 sessions would be required for clients being seen in routine clinical practice. Treatments may occur on an individual or group basis. Hospitalization should be avoided. Treatment setting and duration specific to pain management programs. We just talked about that a second ago, 2 to 6 weeks. A lot of the CBT studies are short term. When we talked about trauma focused CBT a couple of weeks ago, that's also short term. They say between 8 and 12 sessions typically. In my experience clinically, it's a lot longer than that. Pharmacological interventions. So given the lack of firm evidence for the efficacy of med interventions, CBT should be considered the first-line treatment for somatic symptom disorder. However, medication may be beneficial for some individuals who are willing or unable to engage in CBT, or when appropriate psychological treatment is unavailable. Again, you would not prescribe this, but their doctor could prescribe this. So in cases where medication is considered necessary, new generation antidepressants such as SSRIs and SNRIs are the preferred first-line treatment. Individuals with predominant pain symptoms may also respond to anticonvulsants. So that is somatic symptom disorder. The next one we're going to talk about is factitious disorder. So this was formerly known as Munchausen's syndrome, and I'm hoping that some of you have heard of Munchausen's. So factitious disorder is a mental illness in which a person repeatedly acts as if he or she has a physical, emotional, or cognitive disorder when in truth he or she has caused the symptoms. So interesting. People with factitious disorders act this way because of an inner need to be seen as ill or injured, not to achieve a concrete benefit such as financial gain. They are even willing to undergo painful or risky tests and operations in order to get the sympathy and special attention given to people who are truly ill. Some will secretively injure themselves to cause signs like blood in the urine or, like put blood in their urine. Sometimes they try to cut off the blood supply from a particular part of their body, and then the skin will take on a dusky blue color. Factitious disorder imposed on self, which used to be known as Munchausen's by proxy, is associated with severe emotional difficulties. Originally called Munchausen syndrome, named for Baron von Munchausen, an 18th century German officer who was known for embellishing the stories of his life and experiences, it sucked to be him, is the most severe type of factitious disorder. Most symptoms in people with this disorder are related to physical illness, symptoms such as chest pain, stomach problems, or fevers, rather than those of a mental disorder. So in DSM-5, all self-imposed factitious disorders are included under one heading, which is factitious disorder. So people with this syndrome deliberately produce or exaggerate symptoms in several ways. They might lie about or fake symptoms, hurt themselves to bring on symptoms, or alter diagnostic tests, such as contaminating a urine sample. Possible warning signs of Munchausen syndrome include the following: dramatic but inconsistent medical history, unclear symptoms that are not controllable and that become more severe or change once treatment has become, predictable relapses following improvement in the condition, extensive knowledge of hospitals and/or medical terminology as well as the textbook descriptions of illnesses, presence of multiple surgical scars, appearance of new or additional symptoms following negative test results, presence of symptoms only when the patient is alone or not being observed, so I had a seizure or I passed out but nobody saw it, willingness or eagerness to have medical tests, operations, or other procedures, history of seeking treatment at numerous hospitals, clinics, and doctors' offices, possibly even in different cities, reluctance by the patient to allow healthcare professionals to meet with or talk to family, friends, or prior health providers, problems with identity and self-esteem, more comfortable being in a hospital than you might think, and medical knowledge may be quite extensive from many hospitalizations or prior blood work. So some things that individuals do is they might put blood in their urine, inject themselves with feces, or put tight rubber bands around an arm and a leg to cut off the circulation. There are many forms this disorder may take. Sometimes individuals will feign cancer, cardiac disease, skin disorders, infections, bleeding disorders, metabolic disorders, chronic diarrhea, and many, many more. So if you look at the DSM-5 diagnostic criteria, it's split into two sections. So factitious disorder imposed on self and factitious disorder imposed on another. So let's start with factitious disorder imposed on self. So this is falsification of physical or psychological signs or symptoms, or induction of injury or disease associated with identified deception. So the individual presents him or herself to others as ill, impaired, or injured. The deceptive behavior is evident even in the absence of obvious external rewards. So why is this person doing this? And the behavior is not better explained by another mental disorder, such as delusional disorder or another psychotic disorder. And then there's also factitious disorder imposed on another, and this is typically, the other is typically a child. So falsification of physical or psychological signs or symptoms, or induction of injury or disease in another associated with identified deception. The individual presents another individual, the victim, to others as ill, impaired, or injured. The deceptive behavior is evident even in the absence of obvious external rewards, and is not better explained by another mental disorder. So that used to be called Munchausen's by proxy. So here's the epidemiology. Let's see, there are no reliable statistics regarding the number of people in the United States who suffer from this disorder, but it is considered to be rare. In hospital populations, it is estimated that 1% will meet the criteria. Obtaining accurate statistics is difficult because of dishonesty in representation. In addition, people with this disorder tend to seek treatment at many different healthcare facilities, which causes misleading statistics. While factitious disorder imposed on self can occur in children, it most often affects young adults. So let's see. So the course of intermittent episodes characterized by successive deception, contact with medical personnel, which may become lifelong. So this happens over a person's life, and they're doing it multiple times. The onset is typically in early adulthood, often after hospitalization for a medical condition or a mental disorder. When it's imposed by another, onset typically occurs after hospitalization of an individual's child or another dependent. Individuals with factitious disorder are at risk for great psychological distress or functional impairment by causing harm to themselves or others. And then families, friends, and healthcare providers are obviously adversely affected. So, let's see, diagnosing, I think we said this, is very difficult because of dishonesty that is, no we didn't. Diagnosing is very difficult because of the dishonesty that is involved. Doctors must rule out any possible physical and mental illnesses and often use a variety of diagnostic tests and procedures before considering this diagnosis. If the doctor finds no physical reason for the symptoms, he or she might refer the person to a psychiatrist or psychologist, mental health professional who is specially trained to diagnose and treat factitious disorders. So that could be you guys. You guys would use thorough medical history and physical laboratory imagery and psychological assessment tools to evaluate. The doctor bases his or her diagnosis on the exclusion of actual physical or other psychiatric disorders and his or her observation of the patient's attitude and behavior. However, personality concerns are prominent and can make it that much more confusing to sort out organic from factitious etiologies. So this one is very difficult to diagnose. So some questions that you could ask clients who present with this. Do the client's reported symptoms make sense in the context of all the test results and assessments that the client has had? Do we have enough collateral information from other sources that confirm the client's information? And if the client does not allow that, then that's a very helpful clue in, something might be going on. Is the client willing to take the risk for more procedures and tests than you would expect? Have any treatments worked in a predictable way? And if the client claims severe mental symptoms are because of the death of a loved one, the doctor needs to confirm the facts of the loss. The doctor then determines if the patient's symptoms compare to the criteria in the DSM-5, and then you can give them a diagnosis of factitious disorder. So some causes for factitious disorder, an underlying personality disorder. It screams borderline to me, or histrionic. abuse, neglect, or abandonment during childhood, reenactment of unresolved issues with parents, so there's an attachment component to it, and then close contact with another individual that has had a severe or chronic condition. So subconsciously, the client might envy the attention that that other person is getting because of their illness. So here are some treatments for factitious disorder. Medication, antipsychotics, SSRIs, and then family therapy, individual therapy with a focus on the relationship with the patient may help to contain the symptoms of factitious disorder, and then consultations with primary physicians to monitor fake illnesses and injuries. So what's the prognosis for people with factitious disorder? Some people will suffer only a single episode of symptoms. In most cases, however, the disorder is a recurring condition that can be very difficult to treat. Many will deny that they are faking symptoms and will not seek or follow treatment. Even with treatment, it is more realistic to work toward managing the disorder rather than to try to cure it. Avoiding unnecessary, inappropriate admissions to the hospitals, testing, or treatment is important. Individuals with this disorder may produce symptoms by contaminating... Oh, we said that. Let's see. Individuals with the disorder might be motivated to perpetrate factitious disorders either as a parent or by proxy as a caregiver to gain any variety of benefits, including attention, nurturance, sympathy, and leniency that are seen as not obtainable in any other way. So it's important to note the difference between somatic symptom disorder and factitious disorder. So somatic symptom disorder diagnosis is characterized by multiple somatic complaints that are not produced intentionally. In factitious disorder, they're either not true or they're produced intentionally. Additionally, in somatic symptom disorder, the patient is truly experiencing the symptoms and does not have any intention to deceive. So in factitious disorder, the intent is to deceive you for some sort of gain. So on the bottom of this slide is another video that I would like you to watch on factitious disorder. And then when you come back, we will be on the next slide. So conversion disorder is one in which when you watch the video, you're going to be like, what in the world's going on? Very, very interesting conversion disorder. So here is the DSM-5 diagnostic criteria. So one or more symptoms of altered voluntary motor or sensory function. Clinical findings provide evidence of incompatibility between the symptoms and recognized neurological or medical conditions. So you're not quite sure where they're coming from. The symptoms or deficits are not better explained by another medical or mental disorder. And the symptom or deficit causes clinically significant distress or impairment in social, occupational, or other important areas of functioning. So symptoms of this include weakness or paralysis, abnormal movements, gait abnormalities, abnormal limb posturing, sensory symptoms, altered, reduced, or absent skin sensations, vision, or hearing, generalized limb shaking with impaired loss of consciousness, which might look like epileptic seizures, episodes of unresponsiveness resembling a coma, reduced or absent speech volume, altered articulation, and a sensation of a lump in the throat. I can guarantee you that you will not be diagnosing conversion disorder in your office. This again is another one that will be diagnosed medically by a doctor. So here is the epidemiology of conversion disorder. The prevalence is unknown because diagnosis requires assessment and secondary care. So it's found in approximately 5% of referral to neurology clinics. Again, the referral is going to come probably from the primary care physician. The incident rate is 2 to 5 people per 100,000 a year. Maladaptive personality traits are common with this diagnosis. Risk factors include a history of childhood abuse and neglect. Stressful life events might be present. Other risk factors include the presence of neurological disease that causes similar symptoms, such as non-epileptic seizures. This disorder is 2 to 3 times more common in females, and it's comorbid with anxiety disorders, panic disorders, depressive disorders, somatic symptom disorders, personality disorders, neurological or other medical conditions. So those things could be going on as well. Treatment for conversion disorder, for many individuals, it may resolve without treatment, which is totally normal. If you look at the picture on the bottom, that's really what it looks like, what this disorder looks like. And when you watch this video, I just feel like you're going to be like, what the heck is going on? You definitely need medical treatment for this, typically an occupational therapist or a doctor to help. Individual therapy can help with depressive symptoms, anxious symptoms, stress management, coping skills training, and all that stuff that you guys are experts at. So go ahead and watch this YouTube video. It's just super, super interesting. And then meet me back at the next slide. So I hope that you enjoyed the the video on conversion disorders and found it as interesting as I do. We are going to talk about sleep-wake disorders next, and I just could not stand those 3 cute little babies on the left, yummy little sleeping babies. But I thought that this chart might be helpful for you. I typically always ask about sleep when I do an intake, and especially usually each time if one of my clients is presenting with anxiety or with depression, I'll always ask about, even bipolar, I'll always ask about sleep every session. So I thought that this was totally interesting. So infants need up to 18 hours of sleep, and then it kind of goes down from there. Teenagers still need a lot of sleep, 9 to 10 hours of sleep. So those teenagers that sleep until 11 or 12 in the afternoon, that's pretty typical. And then for us adults, we need between 7 and 8 hours of sleep. I know I need between 10 and 11, but this chart is saying that we need between 7 and 8. So that's just something to kind of have in handy in your mind when you are assessing for, depressive symptoms or anxious symptoms around sleep or sleep-wake disorders, which we're going to talk about now. So there are 10 disorders within the sleep-wake disorders in the DSM-5. We're not going to go into depth in all of them. Typically, if there is a persistent sleep disturbance, the client will have already talked about this with their primary doctor or with their pediatrician, and they will have been referred to a sleep study. So I just want to go over these with you very briefly, and then, like I said, this is typically not something that you're going to diagnose in your office. But if you have concerns about a client's sleep-wake patterns, please refer them to their primary physician or pediatrician. So the 10 disorders in this chapter that you read about: insomnia disorder, hypersomnolence disorder, narcolepsy, breathing-related sleep disorders, circadian rhythm sleep-wake disorders, which was in our case study last week, non-rapid eye movement sleep arousal disorder, restless leg syndrome, nightmare disorder, substance medication-induced sleep disorder. This is not going to be shocking to you, but when I learned about restless leg syndrome, I knew that I had it. I was so anxious about it. I didn't really have it, but I thought that I had it. So persistent sleep disturbances, specifically insomnia and excessive sleepiness, are established risk factors for the subsequent development of mental illness and substance use disorders. So if you don't sleep, lots of other things can happen to your body. Lots of other things can happen physically and psychologically. Everybody needs sleep. Sleep disorders are often accompanied by depression, anxiety, and cognitive changes that must be addressed in treatment planning and management. In little kids, sleep disorders can look like ADHD, because if a kid is not sleeping or is being woken up multiple times a night, then they are exhausted and they can't focus in school, and then they get irritable, and then my kid has ADHD, but really, your kid's not sleeping. My own son, Carter, he had huge tonsils and adenoids, and he probably didn't get a great night's sleep. I don't know, he got him out last year, so for the first 5 years of his life, which makes me just sound like a terrible mother. But he wasn't getting a great night's sleep, and he was kind of edgy and irritable all the time, and we were like, what the heck is going on with him? And now he sleeps, and he's like a totally different kid. So sleep is very, very, very important. There is a YouTube video for you to watch at the top, so why don't you go ahead and do that right now, and then I'll meet you back on the next slide. So I hope you enjoyed your video on sleep-wake disorders and that you learned a lot of things that will help you in your practice. Treatment counseling-wise for sleep-wake disorders: relaxation training, cognitive therapy, stimulus control, sleep restriction therapy, and sleep hygiene. So methods such as progressive muscle relaxation, PMR, deep breathing techniques, imagery, and self-hypnosis may help some people overcome a sleep disorder. PMR, we can do that in class if you guys remind me, but involves helping the individual to sequentially tense and relax the body's major muscle groups while concentrating on contrasting sensations of tension and relaxation. Cognitive therapy for sleep disorders helps people with insomnia identify and correct inappropriate thoughts and beliefs that may contribute to insomnia. So those tapes that are playing through your head before you go to bed each night. Cognitive therapy can give people the proper information about sleep norms, age-related sleep changes, reasonable sleep goals, and the influence of naps and exercise. That'll be what you guys are doing. Stimulus control is a practice in which the bedroom is reserved for sleep and sex. Stimulus control derives from the idea that insomnia may be caused by bedroom associations unrelated to those uses, such as stressful situations or TV watching. Therefore, the bedroom should be reserved for sleep, sex, and dressing only. Sleep restriction therapy is based on the belief that excess time in bed makes sleep problems worse. Sleep resistance therapy consists of limiting a person's time in bed to only that time when they are sleeping. So I guess that you could do those two things together. Sleep hygiene refers to practices, habits, and environmental factors that are important for getting sound sleep. The 4 general areas important to sleep hygiene are the circadian rhythm, 24-hour cycle, aging, psychological stressors that cause mini awakenings in which the brain wakes up for just a few seconds, and stimulant use. So circadian rhythms influence when, how much, and how well people sleep. These rhythms may be altered by the timing of various factors, including naps, bedtime, exercise, and exposure to light. So, set up a bedtime routine. Go to bed the same time every night. Put darkening shades in your bedroom, that kind of stuff. Aging also plays a role in sleep. Sleep patterns change after people reach the age of 40. There may be many more nocturnal awakenings as people age. The awakenings affect sleep quality and can interact with any other condition that may cause arousals or awakenings. The more awakenings people experience at night, the more likely they will awaken with a feeling of not being rested. Psychological stressors such as exams, deadlines, or job stress may interfere with sleep. It is beneficial for people to develop some kind of pre-sleep ritual to break the connection between stress and bedtime. Some people find it helpful to make a list of all the stressors of the day along with a plan to deal with them. I would not recommend having clients do this right before they go to sleep because they're never going to go to sleep. But maybe in the morning, that would be a good thing to do. In addition, periods of relaxation, meditating, or taking a nice long hot bath can help a person relax and go to sleep. In terms of caffeine, stimulants can stay in the body as long as 14 hours and can increase the number of times you awaken at night, decreasing your total amount of sleep. Avoid caffeine, nicotine, and alcohol. The effects of nicotine when consumed in high doses are similar to those of caffeine. Alcohol may initially sedate you, making it easier to fall asleep. However, you may be awakened after the alcohol is cleared from your system. Recent sleep research shows that alcohol consumption before bedtime may result in inadequate REM sleep, which the body needs to restore itself. And then on the right, I just gave you a little chart of some of the effects of sleep deprivation. I'm sure from your own experiences and from your own life, you can name a lot of the effects of sleep deprivation. I know that I can. So it's really important to do a lot of psychoeducation around sleep-wake disorders, around healthy sleep patterns. This is something that you'll probably deal with a lot as a therapist, not in terms of diagnosing individuals with sleep-wake disorders, but just in general, using CBT or helping with relaxation techniques or just helping clients to kind of cope with their days. So the next one we're going to talk about is gender dysphoria. So in the 5th edition of the DSM, people whose gender at birth is contrary to the one they identify with are diagnosed with gender dysphoria. This diagnosis is a revision of DSM-4's criteria for gender identity disorder and is intended to better characterize the experiences of affected children, adolescents, and adults. I kind of love the DSM for doing this. So respecting the patient and ensuring access to care. Again, this is from one of those APA little bulletins. DSM not only determines how mental disorders are defined and diagnosed, it also impacts how people see themselves and how we see each other. While diagnostic terms facilitate clinical care and access to insurance coverage that supports mental health, these terms can also have a stigmatizing effect. DSM-5 aims to avoid stigma and ensure clinical care for individuals who see and feel themselves to be a different gender than their assigned gender. It replaces the diagnostic name gender identity disorder with gender dysphoria, as well as makes other important clarifications in the criteria. It is important to note that gender nonconformity is not in itself a mental disorder. I'm going to say that again. It is important to note that gender nonconformity is not in itself a mental disorder. The critical element of gender dysphoria is the presence of clinically significant distress associated with the condition. So, for a person to be diagnosed with gender dysphoria, there must be a marked difference between the individual's experienced gender and the gender others would assign him or her, and it must continue for at least 6 months. So let me skip to the DSM criteria. There we go. In children, the desire to be of the other gender must be present and verbalized. This condition causes clinically significant distress or impairment in social, occupational, or other areas of functioning. So let's see, a strong desire to be of the other gender or an insistence that one is the other gender. That's criterion number 1, and that must be there in order to be diagnosed with this. In boys, a strong preference for cross-dressing or simulating female attire, or in girls, a strong preference for wearing only typical masculine clothing and a strong resistance to wearing of typical feminine clothing. A social preference for cross-gender roles in make-believe or fantasy play. A strong preference for the toys, games, or activities stereotypically used or engaged in by the other gender. A strong preference for playmates of the other gender. In boys, a strong rejection of typical masculine toys, games, and activities, and a strong avoidance of rough and tumble play. Or in girls, a strong rejection of typically feminine toys, games, and activities. A strong dislike of one's sexual anatomy is very important in this diagnosis. A strong desire for the primary and or secondary sex characteristics that match one experienced gender. And then the condition is associated with clinically significant distress. Let's see. Gender dysphoria is manifested in a variety of ways, including strong desires to be treated as the other gender or to be rid of one's sex characteristics, or a strong conviction that one has feelings and reactions typical of the other gender. The DSM-5 diagnosis adds a post-transition specifier for people who are living full-time as the desired gender, with or without legal sanction of the gender change. This ensures treatment access for individuals who continue to undergo hormone therapy, related surgery, or psychotherapy or counseling to support their gender transition. So as long as these individuals are undergoing counseling to support their gender transition, you can diagnose them with gender dysphoria and you can be reimbursed for that. Insurance will pay for that. Gender dysphoria has its own chapter in DSM-5 and is separated now from sexual dysfunctions and paraphilic disorders. Persons experiencing gender dysphoria need a diagnostic term that protects their access to care and won't be used against them in social, occupational, or legal areas. When it comes to access to care, many of the treatment options for this condition include counseling, cross-sex hormones, gender reassignment surgery, and social and legal transition to the desired gender. To get insurance coverage for the medical treatments, individuals need a diagnosis. The Sexual and Gender Identity Disorders Work Group was concerned that removing the condition as a psychiatric diagnosis, as some had suggested, would jeopardize access to care. Part of removing stigma is about choosing the right words. Replacing disorder with dysphoria in a diagnostic label is not only more appropriate and consistent with familiar clinical sexology terminology, it also removes the connotation that the patient is disordered. Ultimately, the changes regarding gender dysphoria in DSM-5 respect the individuals identified by offering a diagnostic name that is more appropriate to the symptoms and behaviors they experience without jeopardizing their access to effective treatment options. So in my opinion, it was a good move on the part of the DSM-5. So here is the criteria for gender dysphoria in adolescents and adults. And we already talked about this. So a marked incongruence between one's experienced and expressed gender and assigned gender, and it has to be at least 6 months duration, as manifested by 2 of the following. So marked incongruence between one's experienced expressed gender and primary or secondary sex characteristics, a strong desire to be rid of those characteristics, a strong desire for the primary and or secondary sex characteristics of the other gender, a strong desire to be of the other gender, a strong desire to be treated of the other gender, a strong conviction that one has the typical feelings and reactions to the other gender. So here is the prevalence of gender dysphoria. In males, these are just modest estimates, and my guess is, with everything that's in the media now and how this has really come to the forefront, that these are way, way, way modest at this point. So it's less than 1% for males and females. In referral rates, though, boys are referred 2 to 1, and then 4.5 times to 1 to girls. In adolescents, it changes. It's almost a 1-to-1 referral. And then in adults, males to females, goes from 1 to 1 to 6.1 to 1. Behavior typically begins in preschool, and the video you're going to watch is, you'll see that. Males with the condition are more commonly have older brothers than those without the condition. I don't even know what that means, but that was in the DSM, so I thought it was important to share it with you guys. Important to consider the presence of habitual fetichistic transvestism, which we're going to talk about, developing into autogynephilia. I don't even know if I said those words right, but we're going to talk about those. The comorbidity, obviously emotional and behavioral problems, and most commonly anxiety, disruptive and impulsive control, depressive disorders, and autism spectrum disorder. I thought the autism one was super interesting too. So, in terms of treatment, there is a whole association, the World Professional Association for Transgendered Health. It's WPATH, and there is the link if you want to take a look at the website for that. So there's and they have lots of guidelines and really great ways around treatment. So definitely take a look at that website. So the overall goal of WPATH is to provide clinical guidance for health professionals to assist transgender and gender non-conforming people with safe and effective pathways to achieving lasting personal comfort with their gendered selves in order to maximize their overall health, psychological well-being, and self-fulfillment. This assistance may include primary care, gynecologic and urologic care, reproductive options, voice and communication therapy, mental health services, and hormonal and surgical treatments. I took that right off their website. So definitely visit that website. And that's a great piece of information for families or individuals if you're working with transgendered individuals. So in terms of treatment, some of this you will do, some of this you will obviously not do. But it's good to know what it is. Hormonal therapy. Cross-sex hormone therapy is a form of gender dysphoria treatment that involves taking the hormones of the preferred gender. For example, a female wishing to become a male would be prescribed testosterone, and a male becoming a female would take estrogen. The primary aim of hormonal therapy is to help individuals to feel more comfortable within themselves, both mentally and physically, and to begin the process of altering the body so that it is more in sync with their gender identity. For some, this may be all that is needed in order to enable them to live with gender dysphoria. A percentage of individuals who do have cross-sex hormonal therapy experience such a change in the way they feel that they do not need to have surgery. Be aware that buying hormones over the internet may seem like a shortcut to transition, but there are inherent dangers, and hormones in particular should be monitored by a specialist in endocrinology that will come via the gender identity clinic if appropriate. So do not tell your clients to ever take hormones over the internet. Gender reassignment surgery, you will obviously not be performing this, but if clients decide that a medical transition will help them to feel more comfortable in their body, then they need to approach their general practitioner for a formal referral. However, having emotional and psychological support while you navigate the medical profession will be beneficial in many cases. The things most transgendered people will tell you about transition is that if it's right for you, then the journey is worth the work. Getting there will take courage and persistence, and in the meantime, they will find benefit in the following tips. So, this is what you can help them to do as their therapist. Build a support network. Identify the friends and family members most likely to support them first and draw on their support where appropriate. It can also be particularly useful to try to find other transgendered people local to them from whom they can draw support. So help them to find appropriate LGBT support networks for advice, guidance, and tips. You can help do that with psychoeducation. Tell them to look into their legal rights. In recent years, various laws have been introduced in a bid to protect transgendered people from discrimination. The Single Equality Act of 2010 in particular has added significantly to the level of protection for transgendered people, building on other legislation such as the Gender Recognition Act of 2004, the Human Rights Act of 1998, the Criminal Justice Act of 2003, and the Public Sector Duty of 2010. So just pointing them to resources, pointing them in the right direction is going to be super helpful. And then helping them to be patient. It can take time for people who knew them as the old gender to acclimate and become at ease with them in the new gender. So you can help them to politely educate people if someone misgenders them, and then be prepared to explain that it's courteous to respect the presented gender. So you could do things like role-playing with them, what that would look like, and helping them with language around that. In terms of counseling, So individual counseling, family therapy, and support groups are definitely helpful. Many people successfully live in a gender other than subscribed at birth, some of whom have had surgical and hormonal intervention, some of whom have had only partial surgery or hormonal intervention, and some who live successfully in their true gender without any medical intervention at all. The important thing is that your client takes the time to work out what suits them best, and that's where you, the skilled and experienced therapist, can help them. So go ahead and watch the video. This is just, there's like a quadrillion videos on gender dysphoria treatment, but this one kind of struck me a little bit after I watched it, so I wanted to share it with you, and I'd be interested to know your thoughts on the video, or how it made you feel when you watched it afterwards. And then meet me back here. So I hope that you enjoyed the video on gender dysphoria. I'm definitely interested to know your thoughts or your feelings around that video, and we can talk about that in class, but I thought it was a good one to watch. So we're going to move right into paraphilic disorders. In the DSM, paraphilic disorders are often misunderstood as a catch-all definition for any unusual sexual behavior. In the DSM-5, the Sexual and Gender Identity Disorders Workgroup sought to draw a line between atypical human behavior and behavior that causes mental distress to a person or makes a person a serious threat to psychological and physical well-being or other individuals. While legal implications of paraphilic disorders were considered seriously in revising diagnostic criteria, the goal was to update the disorders in this category based on the latest science and effective clinical practice. Through careful consideration of the research, as well as of the collective clinical knowledge of experts in the field, several important changes were made to the criteria of paraphilic disorders, or paraphilias, as they've been called in previous editions of the manual. Again, this comes from the American Psychiatric Association 2013 publication. So, most people with atypical sexual interests do not have a mental disorder. To be diagnosed with a paraphilic disorder, DSM-5 requires that people with these interests feel personal distress about their interests, not merely distress resulting from society's disapproval, or have a sexual desire or behavior that involves another person's psychological distress, injury, or death, or a desire for sexual behaviors involving unwilling persons or persons unable to give legal consent. To further define the line between an atypical sexual interest and disorder, the workgroup revised the names of these disorders to differentiate between the behavior itself and the disorder stemming from that behavior. It is a subtle but crucial difference that makes it possible for an individual to engage in consensual, atypical sexual behavior without inappropriately being labeled with a mental disorder. With this revision, DSM-5 clearly distinguishes between atypical sexual interests and mental disorders involving these desires or behaviors. So, the chapter on paraphilic disorders includes 8 conditions, and here they are: voyeuristic disorder, exhibitionist disorder, frighteristic disorder, sexual masochism disorder, pedophilic disorder, fetishistic disorder, transvestic disorder, other specified paraphilic disorder, and unspecified paraphilic disorder, and we are going to go through them. Other changes to diagnostic criteria for 2 DSM-5 paraphilic disorders should be noted. The first concerns transvestic disorder, which identifies people who are sexually aroused by dressing as the opposite sex, but who experience significant distress or impairment in their lives, socially or occupationally, because of their behavior. DSM-4 limited this behavior to heterosexual males. DSM-5 has no such restriction, opening the diagnosis to women or gay men who have this sexual interest. While the change could increase the number of people diagnosed with transvestic disorder, the requirement remains that individuals must experience significant distress or impairment because of their behavior. In the case of pedophilic disorder, the notable detail is that wasn't revised in the new manual. Although proposals were discussed through the DSM-5 development process, diagnostic criteria ultimately remain the same as DSM-4. Only the disorder name will be changed from pedophilia to pedophilic disorder to maintain consistency with the chapter's other listings. So we're going to go through them one at a time, and then there is a National Geographic documentary I'm going to have you watch at the end. That is very interesting. So the first disorder we're going to talk about in this chapter is voyeuristic disorder. So over a period of at least 6 months, recurrent and intense sexual arousal from observing an unsuspecting person who is naked in the process of disrobing or engaging in sexual activity as manifested by fantasies, urges, or behaviors. And then B, the individual has acted on these sexual urges with a non-consenting person, or the urges or fantasies are causing clinical significant distress and impairment. And then the individual experiencing the arousal and or acting on the urges is at least 18 years of age. So it's important to look at developmental level when diagnosing this. The prevalence is most common. This is the most common of potentially law-breaking sexual behaviors. So this will get you in trouble. 12% in males and 4% in females in non-clinical samples. So the male-to-female ratio is 3 to 1. Some risk factors, according to DSM-5, are childhood sexual abuse, substance misuse, and sexual preoccupation and hypersexuality. And then comorbid conditions, hypersexuality, exhibitionist disorder, which we're going to talk about in a second, depression, bipolar, anxiety, substance use disorders, ADHD, conduct and antisocial personality disorders. So those are things that you are all very capable of treating. So this is, you might have a client present with a voyeuristic disorder. And we're going to talk about treatment at the end of the chapter, at the end of every slide that we talk about. So we'll talk about treatment at the end. So exhibitionist disorder, over a period of at least 6 months, recurrent and intense sexual arousal from the exposure of one's genitals to an unsuspecting person. So think like a flasher, as manifested by fantasies, urges, or behaviors. The individual has acted on these sexual urges with a non-consenting person, or the sexual urges or fantasies cause clinically significant distress. So the specifiers to this, sexually aroused by exposing one's genitals to prepubertal children, sexually aroused by exposing genitals to physically mature individuals, or, double whammy, you get both, sexually aroused by exposing genitals to prepubertal children and to physically mature individuals. The prevalence of this is unknown. However, the estimates are at 2% to 4% in non-clinical populations, again, much lower in females than males. Onset is typically in adolescence, when awareness that exposing one's genitals cause sexual arousal occurs, that boys get aware that that's happening, or girls, I guess. It's difficult to distinguish exhibitionistic characteristics from normal sexual curiosity in adolescence, so just be very careful when diagnosing this. Risk factors include antisocial history, antisocial PD, alcohol misuse, and pedophilic sexual preference, childhood sexual and emotional abuse, and sexual preoccupation and hypersexuality. And again, high comorbidity rates with depressive, bipolar, anxiety, substance use disorders, hypersexuality, ADHD, other paraphilic disorders, and antisocial personality disorders. Frighteristic disorder, over a period of at least 6 months, recurrent and intense sexual arousal from touching or rubbing against a non-consenting person as manifested by fantasies, urges, behaviors. The individual acts on these fantasies, acts on these urges, and it causes clinically significant distress. So the prevalence in this, it may occur in up to 30% of adult males in the general population. That's a big number. 10% to 14% are seen in outpatient settings with a presentation that meets diagnostic criteria for Frighteristic disorder. So 10 to 14% of that 30% of adult males. Onset is typically in late adolescence or emerging adulthood. There is no minimum age for diagnosis. However, it can be difficult to distinguish from conduct disordered behavior without sexual motivation in individuals at a younger age. Fewer females than males. And again, high comorbidity rates with hypersexuality, other paraphilic disorders, exhibitionist disorder, voyeuristic disorder, conduct disorder, antisocial personality disorder, depressive disorder, bipolar, anxiety, and substance use disorder. So lots of stuff going on for individuals with this diagnosis. Sexual masochism disorder. So over a period of at least 6 months, recurrent and intense sexual arousal from the act of being humiliated, beaten, bound, or otherwise made to suffer is manifested by fantasies, urges, or behaviors, and which cause clinically significant distress. And then with asphyxiophilia, so if the individual engages in the practice of achieving sexual arousal related to restriction of breathing, you would specify in that. I think of Christian Grey when I think of this slide. So the prevalence is unknown. However, in Australia, for some reason they know the prevalence in Australia, the estimates are at 2.2% of males and 1.3% of females. The mean age of onset, again studied in Australia, 19.3 years. And then individuals with sexual masochism disorder are at a higher risk for accidental death while practicing asphyxiophilia. And then the comorbidity with paraphilic disorders and transvestic fetishism. High comorbidity rate with that. Sexual sadism disorder. So over a period of at least 6 months, recurrent and intense sexual arousal from the physical or psychological suffering of another person as manifested by fantasies, urges, or behaviors. The individual has acted on these sexual urges with a non-consenting person, and they cause clinical significant distress and impairment. So the prevalence is unknown in the general population, but in forensic settings is 2% to 30%, which is a big number again. Among civilly committed sexual offenders in the U.S., less than 10% have sexual sadism. Among individuals that have committed sexually motivated homicides, rates of sexual sadism disorder range from 37% to 75%, so a huge number. In Australia, again, 2.2% of men and 1.3% of women. Information on the development in the course is extremely limited because individuals being studied for sexual sadism disorder are typically in prison or forensic settings. The mean age of onset is 19.4 years, and then it's comorbid with other paraphilic disorders. My guess is that it's also comorbid with antisocial personality disorder, but don't quote me on that because it didn't say it in the DSM, but it seems if you are committing a sexual offense or sexually motivated homicide, you might have an antisocial personality disorder. And then pedophilic disorders. So over a period of at least 6 months, recurrent, intense, sexually arousing fantasies, sexual urges, or behaviors involving sexual activity with a prepubescent child or children, generally 13 years of age or younger. The individual has acted on sexual urges, or the sexual urges or fantasies cause marked distress or interpersonal difficulty. And the individual is at least 16 years old and at least 5 years older than the child or children in criterion A. So do not include an individual in late adolescence involved in an ongoing sexual relationship with a 12 or 13-year-old. I thought this was very interesting because as an 18-year-old, if you have sexual relations with a 13-year-old, 14-year-old, 15-year-old, you can be arrested and labeled a sex offender. However, the DSM is saying you cannot be diagnosed with a pedophilic disorder because you're in late adolescence and you are involved in an ongoing sexual relationship with a 12 or 13-year-old, and there's not at least 5 years difference. So I think that's interesting too. The prevalence rate is unknown, but estimates are at approximately 3% to 5%. It's definitely uncertain in females. It's more prevalent in males. Age of onset is during puberty. Pedophilic is a lifelong condition. And these clients really need, it's about management for these clients. Elements may change over time with treatment, so guilt, shame, intense sexual frustrations, feelings of isolation, psychosocial impairment, or the propensity to act out sexually with children. Those things may be managed through treatment. Risk factors for developing pedophilic disorders include antisocial personality disorder, and sexual abuse as a child, but this is important to note that this is a correlation. It is not a causal effect. This does not mean that every child that is abused will become a pedophile. This does also not mean that every pedophile was abused as a child. It's just a correlational item, not a causal one. Comorbidity with substance use disorders, depressive, bipolar, anxiety, antisocial personality disorders, and paraphilic disorders. And the last disorder that we're going to talk about are fetishistic disorders. So over a period of 6 months, recurrent and intense sexual arousal from either the use of non-living objects or a highly specified focus on non-genital body parts as manifested by fantasies, urges, or behaviors. Again, the urges, fantasies, and behaviors cause clinically significant distress. And the fetish objects are not limited to articles of clothing used in cross-dressing or devices used for genital stimulation. Example would be a vibrator. So many individuals who self-identify as fetishist practitioners do not necessarily report clinical impairment in association with their fetish-associated behaviors. So just because an individual has a sexual fetish, that does not mean that they have fetishistic disorder. It has to cause clinically significant distress or impairment. So such individuals could be considered as having a fetish, but not fetishistic. It's a hard word to say. Fetishistic disorder. So, in terms of treatment for paraphilic disorders, the various paraphilic disorders affect a wide variety of people. The level of severity, distress, and impairment up to and involving criminal behavior resulting from these disorders also is highly variable. Consequently, treatment options vary and must take into account the specific needs of each individual case. Treatment options may include psychotherapy, individual psychotherapy, group therapy, marital therapy, and family therapy, as well as pharmacotherapy or even surgical interventions as indicated. Inpatient treatment is indicated for patients who are suicidal, homicidal, or disabled to the point where they cannot take care of themselves. Suicide risk is high if they feel exposed or confronted. If patients are charged with a crime or have been arrested, they may be incarcerated. Physicians must be aware that not every therapist treats people with paraphilias. There may be a need for consultations with other professionals, such as a neurologist, an attorney, or even a member of the clergy. So this is definitely a specialized area of treatment. I know last semester, for those of you in my multicultural class, my very good friend and colleague, Denise Lambeau, came in, and this is what her dissertation is around pedophilia, and this is what she specializes in. She works for Wayne Behavioral, and she specializes in treatment of paraphilic disorders. So definitely very specialized. So let's see. For adults with exhibitionist disorder, sociopaths excluded, so not those with antisocial personality disorders, group therapy has been effective in improving social skills and providing support against additional offenses. Group therapy has been effective with shy, inhibited adolescents, but not with compulsive, instinctive-ridden adolescents. Individual psychotherapy has been helpful with many exhibitionists. Unfortunately, exhibitionism has one of the highest recidivistic rates of all sexual offenses. Fetishistic disorder often begins in adolescence and usually persists. Treatment of the specific fetish rather than the primary underlying dynamic has not been very promising. Behavioral techniques show some promise, particularly when aided by adequate follow-up. Many individuals with pedophilic disorder have had sexual fantasies about children for a very long time. Consequently, the change can be very difficult. The physician can try to reduce the intensity, or counselor can try to reduce the intensity of the fantasies and help the abuser develop coping strategies. The abuser must be, but is not, often not willing to acknowledge the problem and to participate in treatment. I remember my colleague Denise saying that that's the first thing that they do, that her clients need to take responsibility for what they've done. And if they don't take responsibility for what they've done, they can't move forward with treatment. And because they're all mandated, they have no choice. They have to move forward with treatment. Dynamic psychotherapy, behavioral techniques, chemical approaches, and surgical interventions yield mixed results. Lifelong maintenance may be the most pragmatic and realistic approach. Unfortunately, individuals with sexual masochism or sadism disorder rarely present for treatment until someone becomes an unwilling partner or is injured. The seriousness and intensity of these behaviors often increase over time. Prognosis varies depending on the depth of the underlying dynamics, which are especially poor when psychopathy is involved, and the patient's level of motivation. CBT is used, of course, to modify sexual deviations by altering patients' disordered thinking patterns and making them cognizant of the irrational justifications that lead to their undesirable sexual behaviors. It may be employed in accordance with a 7-step approach as followed. So here are the 7 steps. Aversive conditioning with ammonia or masturbatory satiation. I'm not sure what that means. Confrontation of cognitive distortions, especially effective in groups. Victim empathy, showing videos of victims and the consequences they experience from the patient's act. Relapse prevention, identifying antecedents to the behavior, high-risk situations, and ways of disrupting these antecedents. Surveillance systems, so family associates who help monitor patient behavior. And lifelong maintenance. The incorporation of relapse prevention techniques helps the patient control the undesirable behaviors by avoiding situations that may generate initial desires. The commonly employed technique of covert sensitization pairs a patient's harmful sexual variation with an unpleasant stimulus in order to discourage repetition of the act. Ah, that's what that first one means. This approach has proved effective in many cases of pedophilia and sadism. The next one is orgasmic reconditioning. A patient is reconditioned to a more appropriate sexual stimulus. First, the patient is instructed to masturbate to his or her typical, less socially acceptable stimulus. Then, just before orgasm, the patient is told to concentrate on a more acceptable fantasy. This process is repeated at progressively earlier points before orgasm until eventually the patient begins his or her masturbation fantasies with an appropriate stimulus. Interesting. Social skills training. Because of the widespread view that paraphilic disorders develop in patients who lack the ability to develop relationships, many therapists and physicians use social skills trainings to treat patients with these types of disorders. They may work on such issues as developing intimacy, carrying on conversations with others, and assertive skills training. Many social skills training groups also teach basic sex education, which is very helpful to this patient population. 12-step programs. Many physicians and therapists refer patients with paraphilias to 12-step programs designed for sex addicts. Like AA, these programs are designed to give control to group members who lead most of the sessions. To increase awareness of the problem, the programs incorporate cognitive restructuring with social support. The group also focuses on a sense of higher power and each individual's reliance upon his or her spirituality. Group therapy in this setting, here's the next one, group therapy. I didn't write that up there, but group therapy in this setting is designed to help paraphilic individuals break through the denial they so commonly exhibit by surrounding them with other patients who share their condition. Once these individuals begin to admit that they have a sexual divergence, the therapist can begin to address individual issues that may have led to the sexual disorder. When these individual sessions have been identified, initiation of Gestalt-type therapy with the victim, if any, may be desirable to help patients get past the guilt and shame associated with their particular paraphilia. The goal of this type of therapy is to lead the patient to a healthy remorse. These patients require lifetime therapy to reduce the likelihood of relapse. And then the last one I have up there, individual expressive supportive psychotherapy. Individual expressive supportive therapy requires a psychologically minded patient who is willing to focus on the paraphilia. The therapist should not set unrealistically high goals, but must break through the denial. Patient countertransference and avoidance can be particular problems with this form of therapy. If the therapy enables the patient to break through the denial, he or she can then work on the unconscious meaning behind the particular paraphilia. So some of these treatments are very specialized and are something that you will definitely need more training around once you get into the field. So you can do that if you're interested in working with this population. So there's one more video to watch. It's a National Geographic documentary, and it's pretty interesting. So I hope that you enjoy watching it. What I'm going to do is I have one assessment that I want you to take that has questions from the narrative part of this PowerPoint and from the slides, and I want you to answer those questions. It's just going to be an overview of the information that I think is most important for you to know going forward as a therapist. And then there's going to be a couple of case studies for you to complete as well. And then if you want to just email me that stuff by Friday at 5, that would be awesome. Feel free to do the case studies together if you want. You can definitely ask each other what your opinions are, because remember, as a therapist, you're not going to be working in isolation. You're going to have lots of supervision. But everybody needs to hand in their own copy, just so I know that you were able to complete it. So we'll see you guys soon.